I am very pleased to introduce our interviewer for the evening, Melissa Osborne. Melissa is the Reed Alumni Board President and class of 2013. She received her PhD from the University of Chicago in 2019 and is currently an assistant professor of sociology at Western Washington University to our north. She studies social mobility, inequity, and the role that organizations play in shaping individuals' pathways and experiences. Her current book project considers the social and emotional costs that first-generation and low-income students must negotiate as they experience social mobility during college years. She refers to herself as a mega nerd. I don't call her a mega nerd, but she says that herself. And in her spare time, she enjoys playing D&D and making very impressive miniature dioramas. So Melissa, thank you so much for being here and for volunteering to interview our guest speaker, Acacia Parks. I'll hand it over to you. And hopefully you can, there you go, unmute yourself.
There we go.
There you go.
Hey, thank you for that lovely introduction. So I'm Melissa, and I have the pleasure of introducing and interviewing Acacia Park today. So Acacia is the chief scientist at Happify Health, and her research focuses on digital methods for managing and treating depression and anxiety, as well as chronic health conditions. Her passion lies at the intersection of research and regulatory strategy for digital therapeutics. She received her BA in psychology from Reed College, surprise, and her PhD in psychology from the University of Pennsylvania, where her graduate research helped build the foundation for research on bringing mental health interventions to the general public. Prior to joining Happify Health, Acacia was an associate professor of psychology at Hiram College. And I know you all have your screens off, but join me in welcoming Acacia. I'm super excited about this.
Yay.
So, yay. So I think a lot of folks are probably really curious about the details of your work and what you've been doing and what digital therapeutics actually is. So how about we start there?
Yeah, sure. So I'll start with kind of what digital therapeutics is and work a bit backwards in terms of kind of how I got there. But digital therapeutics is a technical term that describes any kind of digital product that helps to manage or treat a health condition of any kind. So it also implies that it's a digital product that is regulated by the FDA, which is kind of a relatively new concept, and differentiates itself from what are called wellness products, which might be the kind of the gazillions of apps out there you might see that kind of claim to help you feel better or help you live a healthier life, but they're not really targeting a disease of any kind. And so they aren't subject to regulation. That ends up being really important because without regulation, you're not required to be based in evidence. So digital therapeutics, I'm particularly passionate about that movement because it requires a strong evidence base. It requires that things that for a really long time have not at all been required to be high quality. And there's a lot of high quality psychotherapy out there, but it's not required to be high quality. There is no regulation whatsoever. So I got really passionate about this idea of using technology to tackle mental health problems. But like I said, digital therapeutics aren't just for mental health problems. To me, that's where I'm really excited about it, because that's where I see the most kind of painful gap in terms of people being able to access what's out there. Digital therapeutics are all about kind of getting that to the public, but doing it in a way that is responsible and that passes regulatory muster.
That's awesome. So, I think that this is a super interesting field and a really very cool approach to mental health. How about you talk to us a little bit about how you got into that?
Yeah, so I remember when I was a sophomore at Reed, there was a visiting professor in the psychology department who was teaching abnormal psychology and clinical psychology classes. And at that time, even though Dan Riesberg and I thought quite a lot about this topic, they didn't believe that clinical psychology was a part of psychology. They're like, well, you learn basic psychology and then you can go on to do clinical psychology if you want. So it was sort of a coincidence that we even had a clinical psychologist there. And he had a very like health community psychology bent. So his passion was really about kind of how things function in the real world, right? You can do a study and be like, oh, this thing works so great, but like, what if you actually try and take it to people in a real world circumstance? Does it work for them? So he was having us, read all of these things in health psychology and abnormal psychology classes, and I had to write a paper, as one does in a Reed class, and I was around the idea of preventing mental illness. So instead of waiting until a person's depressed, doing something that somehow inoculates them against stress, so that if they are part of the subset of people who are vulnerable to depression, for example, that when stress comes along, they won't become depressed because they have these sort of whatever skills we would have taught you once you became depressed, we can teach those to you in advance, and you can sort of avoid the whole thing. There are lots of reasons why it's really valuable to avoid the whole thing in the first place. So I learned about that concept and started reading. And one of the things I came across was a concept called bibliotherapy. So a few leaders in cognitive behavioral therapy, which at that time was really the only therapy that had a lot of research behind it. And there are many other orientations now, but that was kind of, what cognitive therapy was known for, as being like the one that's research based. And so there have been a couple of authors of cognitive therapy, research papers who had decided to write self-help books. And then they did research using these self-help books where they would randomly assign people to, for example, get psychotherapy or read the self-help book and just sort of work through it like a workbook and teach themselves all the things that they would have learned in therapy. And these studies found that teaching yourself out of a self-help book, if you did it, it's a big caveat, we can talk about that later, if you do it, is just as effective as going to therapy and learning it from a therapist. And this was like made my head explode. It really was a career-forming moment for me to read this paper. So it started at Reed. My undergraduate thesis was about prevention and bibliotherapy. So I had Reed freshmen. I randomly assigned them to read one of these books that contains cognitive therapy, and I saw what happened. And what happened is, when you look at Reedies as freshmen, the majority of them, not all of them, but the majority of them have an uptick in depressive symptoms over the course of their first year. It's just really, it's fucking hard. So there, that when I had a control group of people who I was just following what it was like to be a freshman at Reed, there was this, uptick in depression that did not happen for the people who were reading this book. So that was really cool. I got really excited about that. And it wasn't long before my interest in bibliotherapy evolved into, kind of web-based, and then that evolved into apps, right? So as the technology for self-administered treatments or interventions kind of happened, that changed, but the concept really began at Reed, and then just sort of evolved as the technology evolved.
That's very cool. I always love hearing stories of talking to Reedies that are out in the world doing things, and the kind of web that weaves back to Reed. And I think it's way too often, not way too often, but it is often. So I think that one of the things, right, like when you, the advertisement for this talk, and when one Googles your name, right, it is associated with the word game or gamify or gamification. And I think that kind of that for some folks, right, that those words kind of can conjure up an idea that this is just for fun, right? Or that digital therapeutics don't have the potential to have a real impact that's measurable, right, for real people's mental health, right? But I have had the opportunity to read some of the articles that you and your team have published, and y'all have found some significant and important results for users, and I would love for you to tell us about that.
Yeah, sure. So, I mean, and it's fun for me to sort of start with the most extreme case of, so there's a digital therapeutics company called Acacia, and just in the last few months, they had approved by the FDA a treatment for ADHD that is straight up a game. It doesn't contain games. It doesn't have gamified components. You're like hunting aliens and shit. It's a game. That's pretty cool, right? So I mean, that's not what we do exactly. So so Happify was created by two entrepreneurs who had previously owned a casual game company. So like they made millions of dollars off of addicting people to games really, really effectively. And as they emerged from that, they sold that company and were thinking, what's next? They thought, well, can we leverage this ability to make things addictive or to really make them stick with people for something that's actually healthy, something that's good? Could we do this to get people to exercise more? Could we do it to get people to, practice things that will improve their mental health? So that was kind of the mission of Happify's two co-founders when we met. I was actually at a conference speaking about my dissertation, and they were in the audience kind of looking for somebody they had the whole gamification concept, and they had the best practices for gamification and engagement, and just didn't know what to get people to engage with. And I was up there saying, people, I know what we want people to do, but they don't do it. I have this crappy web page, and people go to my crappy web page, and then they start to read the text. This, but I know what this is. So it was a perfect kind of combination. So at least in our products, we do have games. So for example, there's a concept called heart rate variability, which will be familiar to some people in the audience, but it's basically a physical index of how resilient you are to stress. It's how much you can physically recover from being stressed out physically, which also, most stress has a physical component. So it's kind of like, how quickly do you go back to your baseline? And there are ways to train this by having people breathe in a certain kind of pattern. So we made this game called Breather that's part of this much larger platform. And so it shows you like a little, first you put your finger over your camera phone and it turns the flashlight on, and then it can get pulse information that way. And then it tells you to breathe in a certain way. And if you do it, and if your heart rate responds in a way that's indicative of better heart rate variability, it's got this like beautiful animated scene that like gets more rich. So like at first it's just like an empty ocean floor, for example. And then the more you do it and the more your body starts to respond, there start to be plants and like there's a dolphin and like there's good music and all this stuff. So it's 100% a game, but it is also totally designed to do something really important that is related to better stress management and all these kinds of things. So I think that, and Achille like was another great example of that, where there are these fully like not even gamified, they're games, things that people can do that can be really beneficial. That said, I do think there's a lot of room for gamification elements that just kind of make stuff fun. Like, I don't know, everybody can probably think of some app they do where you get points for doing something and then you earn a streak. And then, you don't want to break your streak, right? It could be exercising or, there are all kinds of ways that things are gamified, and it promotes engagement. Like, who cares about your streak, but like, you don't want to break it. So I think that, it's to gamify something can mean to just incorporate elements that make it feel fun and that make you want to do it for your own reasons, right? Like it gives nobody but you pleasure to keep your streak, right? It's for you because you want to do it. So I do think that there's room for that too, and it doesn't make something less serious. In fact, in a lot of cases, it makes it more serious, right? Because people take it more seriously. One of the things that we find, my first research study using an app as the intervention basically found that you lose the most people between when they agree to do your study and when they actually start your study. Mm-hmm. Like, that's just too much effort. It's Like it's too much effort for them. So, so you lose people every time you ask them to do anything. Anything from like you clicked yes I want to clicking the next button that's like let's start. You lose thousands of people. Like it's you really do have to fight against the fact that they could be watching Netflix instead of doing whatever you're asking. And I think that gamification can really be a panacea in that regard, where you're trying to fight back with something that's equally engaging.
Yeah. Oh, word. I mean, that like number one makes me think about this stupid app that I use that tells me to drink water, and I have these little plants and I don't want them. Yeah. I love them, those little plants. Right.
You should make some miniature plants to like mimic
true, right? And I have teenagers, and so they've got the streak situation. It's like rules their lives, I feel like, all the time. I've got to figure out ways to, put streaks on the dishes or something. One of the things that, I dig about this as well, right, is that, and you and I talked about this in our pre-meeting, that we're both like really invested and engaged in this idea of interventions that can reach a large number of people in accessible and like equitable ways, right? And like too many academic, scientific, and health interventions don't put that to the forefront or incorporate that in like a robust sort of way in their design. And I think that this is a very cool approach to this kind of large scale accessible intervention. And so I think it would be good if you could tell us a little bit about how that idea shaped your approach with this project, its development, and your broader work, right?
Yeah, I had this aha moment when I was in graduate school, because I actually went to work with the first author of the prevention paper that I read that kind of got me all, excited. I went because I want to work on that project. It's going to be amazing. And I mean, it was amazing. Like it was grand scale, and it was a multi-million-dollar NIH study, and it was one of 2 multi-million-dollar NIH studies looking at the prevention of depression that were going on in that lab at the time that I joined it. But over the 7 years that I was there, I realized that once those research projects ended, that was it. The University of Pennsylvania had copyright strangleholds on both interventions, so nobody could ever use them again. So basically the government spent, $6 million demonstrating that something works that nobody could ever disseminate, unless they, there were all these sort of financial, I was so mad, like just thinking about that. It was a struggle. So I kind of had a crisis at that point where I thought like this can't be the way, and part of it was that, in-person interventions are a struggle because you've got this big manual, and then you've got to really like train people to do them, and like who are you going to train and how are you going to pay them, because like therapists are pretty expensive to train and then have regularly implement a program. So I started to really lean away from in-person interventions, which both of those were. And that was one of the changes for me, was to just kind of, I think, it's important to do things digitally, but I also started really leaning away from government funding for the reasons that you articulated, which is that, it's better now. Like there are a lot of grant opportunities that require you to have an industry collaborator so that you're really thinking about how to, use it realistically. And actually, if you look at, there's like a decent sized camp of digital therapeutics companies that buy research tested curricula from the researchers. So like Pear Therapeutics, for example, follows this model. Their insomnia product, Somryst, is something that has had 10 randomized trials done on it by university researchers. And then they bought the rights to it, took it to FDA, got it cleared, right? So it wasn't designed for that purpose. It was kind of picked up. So that is another model. That's not the model that I've tried to follow. For me, I'm just like, let's not even go down that sort of slow government funding path. Let's see if, working in industry, one of the things I've learned is that, when you have a research project, you like ask your CEO and then they say yes, and then you do the research project. Like, it's pretty sweet. I mean, maybe it's not like that for everybody, but I think it is. It's just, you have an R&D budget, and then you just do the studies. There's not like waiting a year to find out if you got the grant, waiting until the grant starts, and then the grant takes 2 years to complete. And so I really got passionate about the idea of moving to industry because of the agility as well. And then the other factor that really hit me was, the scale of dissemination. So the other aha moment that I had was, first of all, it was just in the fact that I was even at this event. So the president and co-founder of the company, Ofer Leidner, and I had somehow gotten ourselves accepted to speak at South by Southwest, which was like, already I was freaking out about this. Like, this is amazing. Like, South by Southwest cares what we're doing. But while we were there, he got an email letting him know that our user base, which at that time was just consumers sort of finding our app in the App Store, had reached 1 million users. And, I had become a college professor for the impact. I really, I loved the idea that, new people would kind of come through, and, we'd get to have the conversations about the things that I'm passionate about, and I could hear, I could get ideas from them. And, I loved that discourse, and I loved the feeling that I was having an impact. But when I heard the number of 1 million, and, now it's more like 4 million consumers and another 6 million covered lives in insurance, like, just the impact is undeniable, right? More people are being reached than were being reached before. And a lot of the people who are being reached through digital therapeutics, it's not like they could have done in-person therapy and decided to stop that and start doing a digital therapeutic. These are people that might never have received any therapy at all. Right? 2/3 of the population that needs treatment for mental illnesses never gets treatment. So there's the access is large, but also I think impactful in that it addresses an audience that might not have otherwise maybe ever gotten treatment, or at least at that moment we're not getting treatment.
Yeah, word. And that makes me think of, this other question that I wrote, right? But because I think this makes me think about, some of my own research, right? Like, because I'm curious about what you think in terms of the potential for this kind of intervention to help fill the gaps for organizations that don't have the labor power or the resources or capacity to provide one-on-one traditional therapy for their populations, right? So, like, for instance, colleges. In my own research, I found that students from underrepresented backgrounds, like first-gen students, for instance, face significant mental health needs during college. Mm-hmm. But most colleges are not yet equipped to provide the level of staffing and support that they need, and they might not ever, right, to serve these student populations. So I'm interested in what kind of potential role do you see for digital therapeutics in partnering with organizations like college and like help colleges and like helping them kind of fill this need that we're, perhaps a little too slowly starting to realize is like critical.
Yeah, so digital therapeutics is probably the third evolution of our company's I don't know, it's the third kind of permutation of what we've done, but the second after consumer was direct to business. So we started working with both health plans and large organizations to offer this kind of mental health app. And it's a place that we've had some traction, but it's really interesting that you bring up universities and colleges, because it's like, it hurts my heart, right? Like, this is something it was one of the first things I thought when I joined Happify. I was like, oh, Hiram's full of first generation college students. Like, they're really stressed. There's a high dropout rate. Like, surely they're going to be interested in this. They were not interested in it. And it's not specific to Hiram, because Happify has gone hard over the years to universities and colleges on this issue. And, we've made it to the point of, talking in depth with some of them, but the interest doesn't seem to be there, which I find really interesting, because you'd think like colleges stand to make money by retaining students, and the number one way that they're losing students is with mental health issues. They go untreated. And you're so right, by the way. Every academic institution I've been involved with, other than Reed, has had issues where, you know, it's 6 months to get in to see a therapist. It's nuts, but it's the norm, at least in the United States. There are some countries where I'm like, I've heard people say that's not an issue, but in the United States, you know, huge wait times. So the need is there, but the traction with universities is not. And I can't say, I don't know why. You know, when you fail to get a deal, you don't ever really get good feedback about what, but it doesn't seem to be somewhere they're willing to spend money.
Yeah, that's super interesting. And I think, you know, very potentially has to do, like, I think a lot of colleges and universities like still don't see that as part of like their responsibility or their purview, right?
Yeah.
They are still conceptualizing themselves as like a knowledge-based organization, although they're businesses, right? But the like student need side of things, especially in terms of mental health, right? Because they're like, it's a liability, and that is a
well, they're like, they have insurance, right? So like they can go somewhere else. But like, to give you an example of Hiram, like poor Hiram students live in the middle of nowhere. It's a 45-minute drive in a car, which they may not own, to get to Cleveland, where there are actually any therapists or psychiatrists. So, you know, colleges can say, oh, you've got insurance, you can use it, just go find somebody in your network. But like, there are logistics involved in access, especially in rural areas where, you know, if I wanted to see a psychiatrist in person, I'd have to drive an hour and a half.
Yeah.
So yes, I do think you're right that there's a sort of a kind of pawning off of responsibility that it's been really upsetting.
Yeah, same, agreed. I guess, you know, I imagine that some folks, right, kind of thinking through this, right, especially with this idea of thinking about these kinds of interventions and where, you know, the role that the gaps that this could fill. But I imagine that some folks might be concerned that digital therapeutics are meant to replace professional human therapists, right? Like, so if I can just pop onto my phone and do my own thing and like see the ocean populate, which sounds very cool, and I need to go check that out. What becomes the role of a therapist, right? Like, what I imagine, you know, what are your thoughts on that?
Yeah, I mean, it's a multi-layered thing, right? Because on one hand, as I mentioned before, right, there are these staggering statistics about people with mental illness being able to get treatment at all. So to suggest that a digital therapeutic replaces therapists implies that everyone who needs a therapist could get one if they wanted to, and that's simply not the case. So, you know, kind of argument one is that there's not always overlap between who would pursue one or the other. But the other side of that coin is, and if I may be so bold, FDA is not going to approve a digital therapeutic unless it works. That's what the FDA is for. And I would never want to give something to the 2/3 of people who are unable to get treatment for whatever reason, or who don't, that isn't as good as a therapist. That would be shitty, right? Those people don't deserve something that's as good as a therapist. Like, but that said, I mean, I don't feel that therapists should be threatened, because there is plenty of need to go around, especially now, you know, during the pandemic. So like, I have I use like a doctor on demand, right? I have a therapist through doctor on demand. And when I hadn't seen her for a while, but when the pandemic hit, probably like everybody, I started getting anxiety and, you know, panic stuff. And so I made an appointment with her, and she's like, you can't even schedule appointments with me anymore because I'm so overloaded with people who so desperately need help with exactly what you're describing, right? So there isn't enough therapist bandwidth anyway. So I think it's ethical, and it's ethical to provide something else. And it's important that that something else is pretty freaking good. You know, I don't think it makes sense to kind of to worry in that way, because there's a crisis of lack of care, even with all of the therapists seeing as many people as they possibly can.
Yeah, absolutely. I think that right, like with most things, that kind of really thinking through the like sizable population that doesn't have access to resources, right, kind of becomes the straightforward kind of answer to these kinds of things, right? Like, if there are folks that don't have access, then let's provide them something that works, you know, and that they can have access to. You know, we're almost ready for Q&A. I guess my last question is, I'm interested in kind of, you know, what you're thinking about now and like what's next.
Yeah, I mean, you know, it's FDA approval is like the next frontier. We've met with the FDA a couple times, but it's a multi-year process. So I'm becoming. You'll even notice, like in my bio, I mentioned regulatory strategy, which like a year ago I would have been like, "We're never going to go for FDA approval. Regulatory, what? That's for stodgy people. I don't do that." Like, I'm obsessed with it now because it is such a delicate dance of negotiation, where FDA's got what it's comfortable with, and you're trying to do something that is completely different from that, right? There's just not enough precedent. So, you know, I think if I were like at a cocktail party and I was like, "Oh, FDA clearance, yeah, so exciting," people would be like that doesn't sound exciting, but it really is. It's a really it's a challenging puzzle to disentangle, because you're trying to find a way to do something that, you know, the body you're speaking with won't like because it's not something they've seen before. And you really have to think about kind of like, where do you want to innovate and where do you want to stay old school, and kind of do what they're comfortable with. It's a pretty interesting challenge, but it's really the kind of last barrier. You know, we're one of the few companies that has things from like wellness and patient communities and social media, all the way to kind of prescription products, that whole kind of spectrum. And that will be kind of the last feather in our cap, is to get there. So I'm pretty excited about it. You know, it's still all about impact for me, but I think this is the way, you know, for a psychiatrist or a GP, or even better, a GP, to be like, "I've got this client who's depressed. I don't know what to do." To have a box that they can check that is an app, right? And especially, this is a bit of a tangent, but you know, I know there are health systems that are penalizing people for prescribing antidepressants. They want patients to get therapy. They don't want them on drugs. So the wait list is 6 months for therapy, and they're essentially put in this horrible position of having to refer a patient they know will now not get treatment for 6 months, or take a penalty and prescribe them an antidepressant. So, you know, my perfect world is being able to provide a different box they can check in their EMR that will let them prescribe a digital therapeutic instead.
That's very cool. I mean, in the matter of 3 minutes, you made me go from being like FDA approval snooze fest to, okay, this is actually very
I tried. Well, I'm pretty excited about it anyway.
Yeah, that's great. I think that, okay, so I think we're going to move on to Q&A. Is that correct? Yes, I'm looking at our schedule. Cool. All right. So I
am making bold some things that look cool to me.
Cool. Yeah, so I'm going to start with this top one. So Acacia mentioned understanding your baseline level of stress, but how does that apply in a time like the last 6 months when it's been unprecedented rolling stress?
Yeah, I mean, I'm not going to promise I have a good answer to this one, but I will acknowledge that, as I mentioned before, I'm grappling with it myself, right? Like, I have never had anxiety in my life, and here I am, like, wishing I had access to a whole other set of digital therapeutics. So, I mean, a couple of things, right? One is that the types of symptoms that are emerging as people have been stressed for the last 6 months are not magically different. There are treatments that are research-based for all of these symptoms. They're different types of anxiety. They're panic disorder, they're generalized anxiety disorder. The therapeutic treatments are still effective now, right? So, you know, if you can get, you know, if a person is experiencing new symptoms, if they can just get a sense enough of what it was called, like what that diagnosis would be, the same research-based treatments that worked for a person with panic before COVID work for me now having panic attacks during COVID, right? COVID hasn't changed anything about how people are responding to evidence-based treatment. So that's actually like really good news. I mean, it's still really hard work. Like treatment for anxiety using therapy is really tough, but it works just the same.
That's super interesting. I mean, I guess good news, right?
I mean, insofar as we can, yeah. It's terrible to be experiencing it in the first place, but yeah.
Okay, so we've got a question. Psychotherapy research has shown that common factors across therapy approaches account for more of the change in therapy than the specific interventions within approaches. One of the most important common factors is the relationship between the patient/therapist. I'm wondering if the research you've done shows any parallels in the digital health space.
Yeah, so actually I haven't had a chance to talk about this yet, but one of the things, a really important component of the digital therapeutics that we're developing is artificial intelligence and the use of highly proficient chatbots that are trained by therapists. So there are a couple of companies, and we're one of them, that has worked pretty extensively to train a chatbot using therapy transcripts so that the chatbot talks like a therapist and mostly doesn't say stuff that's dumb. I mean, you can never prevent completely that a chatbot might say something dumb, but it's amazing what it can do. And so to give you an example, actually probably one of the first things we conceived of, other than just sort of giving a feeling of the therapeutic alliance, which I'm telling you, like we just finished a study this week that is suggesting patients really do feel a therapeutic alliance with this clearly a robot. People do feel like, they have a connection, they feel understood, right? It stores information about them. You mention your wife's name, and then it's using your wife's name next time you talk about your wife. So there's this sort of like non-specific factor that can be cultivated using artificial intelligence with the right training. It's taken years of like, we have a legion of therapists who go back through and say like, don't ever say that again, Anna. She's the name of our chatbot. So there is definitely a process involved, but there is that ability. The other advantage of using AI, which I think addresses another one of these questions about kind of how do you decide what's appropriate for the given patient. The answer is, again, AI, right? So if you have a smart chatbot that is collecting information about people, eventually you have all that information. You can start to do research about what predicts who responds to what, and then you can start to kind of proactively, next time you get that information and you see that you have patient profile X, you know what to recommend to them. Now, there are complicating factors there because the FDA does not like things like that. The FDA does not like the idea that there might be 20,000 variants of your treatment, depending on all of these individual parameters. That is not their style, right? They want to be like, I gave it to them at this dose or that dose. Like that's the level of variation. I mean, think about drugs, right? Drugs don't have 20,000 variants. So when you go back to what I was saying before about this, kind of delicate negotiation with FDA where they are comfortable with things this way. And over here, you've got like AI doing all kinds of crazy shit. Like this is not what they want to see. And, it is a challenge to think, from a strategy perspective, how you're going to gradually get them to a place where they can see this mess and make sense of it. But it is a possibility in terms of, the sort of customization or person activity fit as well. I mean, there are some more obvious kinds of like, if a person doesn't have access to technology or they have some sort of physical limitation, maybe it's not the best fit for them. But I'll tell you, we have a product for MS, multiple sclerosis, and like we changed all the games to work with various physical limitations. We changed a lot of the physical activities we suggest people to do using, stakeholders from MS patient communities. So a lot can be done too if you have a particular group in mind to customize as well.
Yeah, that's super interesting. Yeah, the chatbot thing, interestingly enough, they use that in college advising for students from underrepresented backgrounds that don't have access to college advisors in their high schools as well. And a very similar, like, there's all of these different scholarship foundations that basically had their recipients be, fed information into these chatbots so that they could do the same kind of thing in a way that I was like very skeptical going in. I'm like, this is not. And then
I mean, it can be pretty terrible. I mean, it really depends on what kind of, what kind of code you have going on and who's training the chatbot, right? Without
absolutely.
feedback, a chatbot knows nothing.
Yeah, and like seeing the kind of projection of it, because I participated the first iteration and then a year later another round of it, and I was like, oh my god, okay, now it's not creepy, now it's creepy in a different way, it's good. Okay, this is not, I don't know about that. Okay.
Oh, I found one that's for both of us.
Oh,
this one about patient disparities.
Ooh, cool. Okay. Are there are there patient disparities that can be magnified, such as age, tech savviness, by a digital therapeutic versus traditional therapies? If so, is there anything being done to address this?
Yes.
Yes.
I mean, give me a second to formulate, but Melissa, I know you have thoughts on this as well in terms of, accessibility and disparities and these sorts of things.
Yeah. I mean, I think that, right, like, the first thing when I started looking you up, I was like, the first thing I started thinking about was disparities in terms of tech access and tech usage, right?
Yep.
I was like, okay, so how is this going to work? Right, like there's entire populations of people that it might never reach, for sure, right?
Well, like research studies do these goofy things where, I have a really excellent director of clinical operations who, had initially said, oh, when we do our clinical trial, we'll send tablets to everybody. And I'm like, what?
Yeah.
We're going to send tablets to everybody? Because, I mean, I get that we want to have as inclusive of a population, but it feels like a Band-Aid to me, right? Like you want your study population to be inclusive, but then the actual population that can receive it won't be inclusive at all, right? It's a temporary solution. It's a pretty big one. But I also wonder to what extent, and I hope you'll push back or have thoughts, but to what extent this is a temporary problem, in the sense that technology becomes more pervasive every year. So, at least by the time any of our products are FDA cleared 2 or 3 years from now, I wonder how difficult it will be for people to gain access to an electronic device that would let them use this.
I actually agree.
Yeah, I don't know.
I do agree. Yeah, because I think that, so before I did work with college students, my work was with homeless populations in Chicago. And I would say at about a 95% level, they all had cell phones. And most of them are government issued, right? But they're smartphones at this point, right? People are not getting flip phones unless they choose to get flip phones, right? And so, and as long as they can get on the Wi-Fi, then they would have access to apps and be able to access the technology. And I think that most folks, I mean, with like ability issues aside, in terms of like, ability with accessibility and like using the screens, and stuff, I think on the tech level, many folks are kind of on the page at this point.
Well, and in terms of the accessibility pieces, that one's a little easier too, just because most organizations that digital therapeutics companies are working with require WCAG compliance, and you have to have various types of accommodations built in, and that's assuming. I mean, that's just those are obviously very broad guidelines. But again, if somebody is thinking about a specific patient population where you have certain common limitations or differences, that's something that I've definitely seen companies tackling to make sure that's the case. The technology access, and I hadn't thought about it, but the wireless things is actually really terrible.
Yeah.
You just can't even get high-speed internet in places, and like nobody thinks about that. But I had a friend who couldn't get high-speed internet for the first 10 years she lived in her house. She had to go to her office. So those technology things can be difficult. So I mean, I think on one hand, I think people are working at it, but at the other hand, I think there are certain aspects of this people are expecting to solve itself as well.
Yeah.
Nobody's going to solve WCAG compliance unless you just do it. But we did it.
I mean,
possible.
And I think that, right, like these kinds of issues that get highlighted by these kinds of interventions are really, it's shining a light on the, more systemic and structural inequality that we have in our society, right? And that doesn't mean that these interventions shouldn't kind of, try to operate in a way to reduce those, but it's, it's part and parcel of a much larger systemic issue. Okay, now I'm looking at the questions.
Yeah, we've got one about, I can answer pretty quick while you're looking at other ones, about just FDA and their standards of approval and where they get these things from. So there's a group called the Digital Therapeutics Alliance, of which Happify is a member and I am a representative. And the Digital Therapeutics Alliance goes to FDA and also to health plans, by the way. So like they've made a lot of progress recently with Medicare, right? CMS. Everybody calls it CMS, but like I'm like, how is that the same as Medicare? Anyway, I don't assume people know, but anyway, progress with Medicare reimbursing digital therapeutics, which is freaking incredible because up until recently, nobody was reimbursing digital therapeutics, right? No health plan was saying, oh, if you use this, you'll get paid for it, right? That's a really big barrier. So the DTA, the Digital Therapeutics Alliance, is a really important piece of that. They do not talk to APA or other kind of psychological or scientific organizations. In part because those organizations don't necessarily have a vested interest in digital therapeutics, but the DTA is a professional organization, and they have been quite helpful in having individual companies go to FDA is just little noises. So it's important to kind of come together as an industry.
Yeah, awesome.
There's a lot.
Yeah, there is. Sorry, everybody out
Some
there.
of them are long. I'm trying to read them, but I'm like trying to talk at the same time.
So what are, I guess kind of, what are Happify and other digital therapeutics doing to kind of move the needle on more than just the service delivery model to like help us broaden our understanding of mental wellness?
I mean, digital therapeutics, I would say by definition, are doing nothing to broaden understanding of mental wellness because they must be specific to a disease and its treatment. So, I mean, I do think that there are a couple of companies like Happify that sort of focus on the whole spectrum, but more than that, there are like companies that focus like just on the wellness piece. And then there are companies that are just in the sort of like management of symptoms, but they're not really treating something space. And then there are people who are treating. So like Noom is actually a really great example of this. I don't know if you've heard of Noom. It's a weight loss app. I mean, they have, billboards in, Times Square, which is actually a really good indication that they are not a regulated product. Because, usually if you see a pharmaceutical, ad, it's got like 5,000 little like caveats with asterisks, and it's just like, Noom, gonna rock your world, I don't know, whatever it is they say, right? But Noom also has a version that treats obesity. So, diagnosable disease, treats hypertension, right? Treats specific diseases. So they do have particular aspects that they're trying to make regulated. Anyway, so I mean, I think it's hard to answer that question because there are business reasons why most no product spans all of those things, right? FDA is not interested in regulating wellness. They even have a whole class of management things they also have said they don't really have a lot of interest in. So, FDA is really only, and as soon as you combine them, then you lose FDA's interest. So there's not a good reason other than a logistical one for why that is the case.
Yeah. I feel like weird phone listening moments have happened where I'm just talking about, I don't know, like tomatoes I grow, and all of a sudden Noom is like, did you want this? And I'm like, no.
Well, it's funny too, because I saw their CEO give a speech once, and I swear to God, he said fuck at least 20 times. Like, this was at a conference. Like, I don't even, but why? Like, there was no, anyway, he's kind of my style. I don't know. I liked him.
Edgy.
Yeah.
We have a question. Do you know if there's digital therapeutics that have been used to help people with substance use?
Yes, the first FDA cleared digital therapeutic was for substance use. It's made by Paratherapeutic, and it's called Reset. And then they have one specifically for opiate addiction called Reset O. It is the only one that I'm aware of that is cleared or close to being cleared. But again, I'm not intimately familiar with the product because I don't have a prescription for it, but it exists.
Cool.
James is right. Garbage in, garbage out when it comes to training AI. That's certainly true. I'm not an AI specialist, so I wish I had a smart answer for you, but especially like knowing whose question I am answering, I can't pretend that I have an answer that will satisfy you, James, but you're right, of course, garbage in, garbage out.
Oh my gosh, too many questions. Oh my gosh. Okay.
I know, I'm trying to respond to some of them like privately, just that I know we won't get to.
Yeah. I guess there's a question here, and it goes back to something you said before about the self-help books and about whether people actually use them as a workbook or not, right? And there's a question here about what helps keep people engaged in digital therapeutics, especially if you have treatment needs that are lifelong. And I'm like, that's been spinning in the back of my head since you said it. I'm like, okay, yeah, exactly. Like, what is it like? I don't know, right? Like I imagine sometimes my plants die on my app, right? Because I get busy or I stop worrying about my water plants. And I'm interested in what helps keep people engaged.
Yeah, and I mean, it's complicated, and I know I keep saying that, but we are, especially in the prescription world, we are restricted by the need to have a treatment start and end period that is discrete. Because if you don't, basically your FDA label only says what your study shows, and your study has to end at some point. So typically, the duration of treatment that your label indicates is going to be between 8 weeks and 3 months. And after that, like, the study ends so you can get your FDA clearance. So that doesn't mean doctors can't prescribe it for longer, but unfortunately products just aren't made for that, right? Products have to be made to sustain what they're doing for FDA to please FDA. So that's kind of an issue we haven't quite solved yet. With a drug, it's like, if you stop taking it, it stops working. But that's not the case with therapy, right? Therapy teaches skills. And if you learn to practice the skills, often people internalize the skills. You don't actually need the app anymore. Or, I mean, at least with cognitive therapy or mindfulness-based stress reduction therapy, both of these things are designed for you to do for 8 to 12 weeks and stop.
Yeah.
Or maybe go back every month or every couple of months for like a booster or something like that. While medications, you stop. Anyway, so there are issues with that. So let's push that aside for a second and hang out where I'm a little bit more comfortable, which is what's called enforcement discretion. Like, these are things that FDA acknowledges are relevant to disorders, right? So they're not wellness products. FDA technically should look at them, but they're like, I don't have time for that. There's too many of them. They're not that high risk. I'm just going to not, right? Mm-hmm. That's what enforcement discretion is. So if I had something, for example, that I'm making claims helps manage symptoms of depression and anxiety, it's not supposed to replace anything. It's not a treatment. It's just kind of like something there. I can play a lot more with AI there, right? Because I can have all these variations, and FDA is not looking closely. Like, they've promised they're not going to look closely. That's what enforcement discretion is. And with there, I have a bit more latitude in terms of long-term engagement. So like when we first made Happify as a consumer product, it was something that was designed for people to use for years. And that's what they did. Like I have data sets of people using it for years. And it's, you know, something where you pick the things you like the most and then you use them like as you see fit. So in the enforcement discretion world, maintenance is something that's totally possible using these kinds of gamified frameworks, right? You get sort of continuing engagement. I think, you know, things like an AI chatbot kind of sending you a text message and being like, how are you doing, could only help, right? In terms of just like encouraging you to check in once a month. We have a lot more latitude there. It's harder in the prescription world just because we have to somehow make what we're doing fit in what FDA expects, despite the fact that we're nothing like what FDA expects.
Yeah, that makes a lot of sense. That's, I mean, complicated.
Yeah, welcome to my life.
Right, for sure. I think that is it in terms of time for Q&A, and Olga's gonna wrap us up, but before she does, thank you. This was super dope, and I really appreciate getting to chat with you in front of tons of readies, you know?
Yeah.
Woo!
Thank you very much to both Melissa and Acacia for taking the time to be here this evening. I can say that this topic I know hits home for a lot of us. Mental health issues, you know, hit you right at your heart, especially when you know someone who you love who's suffering. And so many of us are feeling some pain right now due to the status of the world. So this topic is, you know, just, I'm very grateful for you both coming and bringing this right into our living rooms. As we wrap up, I just wanted to ask if anyone does have feedback for tonight's presentation. I will be sending out an email in the next few days, but I'm also going to throw something in the chat. If anyone wants to fill out a little, give us feedback about tonight's presentation, I just put that in the chat room. I'd love to get your feedback about presentations that you'd like to see in the future. You know, this Read Remote Talks series is, we're just trying to promote the work of our alumni out in the world. So I think this is a great example of some excellent work that's being done that we just need to broadcast these messages wide and far. So that is there. And if you enjoyed the talk, we have another one happening on September 30th. We're going to be bringing Pamela Ronald, class of 82. She's going to be talking about improving food security for the world's poorest farmers and her role in developing climate-resistant rice. It's a very interesting topic, and she'll be with us on the evening or 4 p.m. on September 20th. I'm also going to put the website where we are promoting all of our Read Remote programs right into the chat. There you go. So you can stay in touch with us, please. I know this is a time when we're all feeling separated for many reasons, but we in Alumni Programs are here to try and bring us a little closer. So come back and visit us for another talk, and please let me know what you would like to see, how we could help you. I wish you all, especially those of you in the wake of these crazy wildfires that we're having right now, or cities of unrest, you know, there's a lot going on. So take care of yourself, get on the Happify website and see what you can do for yourself there.
Oh, guys, if anybody actually wants to play with Happify, please email me, because there's a paywall, but I can remove the paywall if you want to play with the full product. So like Breather, for example, is behind the paywall, but it takes me like 5 seconds to remove that. So just I'm just acacia@happify.com.
Got to get that ocean thing going.
Woo, it's fun.
Use I was hoping that could have been.
It sounds really nice.
I was hoping
I used it in VR. It's nuts. Like they put with the headset, and then there's like a whale. Oh my God.
Oh.
Anyway.
I love it. Okay. So thank you to everyone for being here. We will see you again soon. And we'll follow up with some resources after this via email. Have a great night, everyone. Bye.
Thank you.
Thanks.